This is a really good episode. I'm so excited to have my friend and colleague, Dr. Alyssa Hertz, on here with us today.
Katie did a whole wonderful podcast on that. And, um, you know, OCD is really anything that you care about. If you care about it, it's going to go after it. And in really helping people to see like it's pretty broad. And that's why people's symptoms can be so all over the place when you're working with them.
Welcome back to Heal Your Roots podcast. I'm Kira Yakubov-Lashansky, co-host, and we have a very special guest co-host joining us today, Dr. Katie Manganello, licensed psychologist, and a very special guest, Dr. Alyssa Hertz, also licensed psychologist. Today, we're going to talk about the overlap between obsessive compulsive disorder and eating disorder. Ladies, thank you so much for hosting and for being a guest with us today.
Thanks for having me.
Yes, I'm so excited to have Alyssa on the podcast with us, Dr. Hertz. Fun fact, we went to grad school together. So this is,
Didn't.
my way of being able to pull in my colleagues that have some overlapping interests and some cool stuff to share. So I'm really excited.
So, Alyssa, we usually start each episode kind of learning more about the practitioner. So, if you can share kind of your background, how you got into mental health and your specific specialty.
Sure. Um, I wish I could say that it started by like my family was a psychologist or like this strong desire to help people. But I think for a while I wanted to go into nursing school because my mom and sister were. But going to college, I had no idea what I wanted to do. So I took psychology courses and it kind of just stuck. I was like, I'm good at talking to people and I'm good at listening to people. This is the perfect career choice. But overall, it really did start to stick. I actually found it to be really fascinating and just seeing all the different ways you could actually use a psychology degree to help people. Um, I think from a really long time, I've always had an interest in the eating disorder route. I was just fascinated by it just because it's a little different, in my opinion, than some other presentations, right? Like you don't need to drink alcohol or you don't need to maybe engage in certain behaviors, but you need food to live. And the fact that people just stopped eating or kind of were engaging in these really dangerous behaviors stuck out to me a lot. So I had loved that and took a lot of courses in undergrad, my master's program, my doctorate degree. And then I started having a lot of curiosity about OCD and ended up at a training site with OCD and just seeing a lot of overlap between people with eating disorders, people with obsessive compulsive OCD. And realizing that there's a lot of symptom similarity between the two of them. And I thought it could be a special training opportunity and niche to be able to say that's something that I specialize in both routes. So really a lot of my background and training has been working eating disorders, training in cognitive behavioral therapy enhanced, which is for eating disorders, and then family-based therapy. And then on the other hand, doing a lot of training in exposure and response prevention treatment as well for OCD. And then I found a job that actually married the two together, and
Hmm.
I kind of never looked back from there.
That's awesome. That sounds really cool.
Yeah.
And so, can you share a little bit about who you work with now and the type of population? I know it's the overlap, but do you see clients only for one, or they have to have both, or what does that kind of look like for you?
Yeah. So the practice I work for, our kind of bigger specialty was eating disorders, and we recently kind of branched out to starting to see OCD, anxiety related disorders, PTSD, things like that. Again, just because we're starting to paint this picture of the two go together pretty often. So we really probably within the last couple of years have started branding ourselves as a clinic that specializes in the overlap between the two. Now, in order to be seen by one of our practitioners there, you do not have to have that comorbid presentation. But it's kind of just like a nice option if you are struggling with both. And I think there's a lot of times too people don't understand that it's one or the other. So having someone that can really tease us apart of, hey, you actually meet criteria for this, or you meet criteria for this other thing. This is how it's impacting your disorder, or this is how it's impacting your presentation. So yeah, I think it just creates a kind of one-stop shop for people to be able to go to.
And so, for the listeners who may not be as familiar or may not know, can you kind of share what eating disorders are and some of the common subtypes?
Yeah, of course. So eating disorders, they're psychiatric conditions. They're cause pretty significant impairment in someone's life. And I think if we're looking at them more, I guess, generally, it's really this just intense preoccupation and fear with weight gain, their body shape, their weight, and this extreme desire to be able to control these things. And they're they're dangerous eating disorders. They're very, very harmful mentally and physically. You could go on Google and type in physical complications of eating disorders, and you're going to get a, a list. Some of them cardiovascular issues like irregular heartbeats, people that have heart attacks, GI issues. So when we're not eating enough, there's a lot of kind of just like not going to the bathroom regularly, a lot of GI distress, substance abuse. People don't know how to cope with it, so they're kind of turning towards alcohol. But probably, I think the other part is like the suicidality piece. So eating disorders have highest suicide rates than any other psychiatric condition. So, when we're talking about treating eating disorders, we're thinking about this fast action approach. We really need to get people kind of quick into recovery. Um, Common types, there's a few. There's several different eating disorders. I think probably what more people are familiar with or have at least heard at some point in their life, anorexia nervosa, bulimia nervosa, and binge eating disorder. Um, so anorexia is just this really intense preoccupation and fear about weight gain. Their thoughts and emotions that accompany food-related behaviors. This leads the person to restrict. They're eating a significantly less amount of calories today, skipping a lot of meals and snacks that people need throughout the day. So really the hallmark feature of anorexia, and I think probably what most people are familiar with is that low body weight. And we're talking about not like 1 or 2 pounds below maybe your growth chart, but it's inappropriate for your developmental level. And that's where we see a lot of those complications start to come in. And I think that's the picture, right? If you tell someone anorexia, they're thinking really thin, you can see like bone structure. They don't look very well, but there's also a binge purging type as well, where people are engaging in binge episodes, which I'll explain, engaging in purging episodes, but really it's that weight piece, right? That is the defining feature there for anorexia. Um, Bulimia is someone who repeated binge episodes. So difference between binging and overeating, we're all susceptible to overeating. Thanksgiving, Super Bowl, parties, we all overeat from time to time. Binge eating is really this unusual amount of food that someone's eating in a really short period of time that characterizes it as a binge. A lot of the times I hear people talk about they can't control it. They like blacked out during like an episode of eating. They don't remember consuming all of that food to manage a lot of the maybe fullness and distress that comes with the binge eating. They do compensatory behaviors, which basically is just a way of trying to get rid of everything that they ate. So we'll see self-induced vomiting, laxative abuse, excessive exercise, and those are kind of some of the common ones. And then the last one, binge eating, pretty similar to bulimia with the binge eating periods, but there's no compensatory behavior. So they're not trying to get rid of the food. And something interesting in binge eating too is you typically aren't seeing this intense preoccupation with like weight, shape, and food as you would with some of the other ones. But there's a lot of guilt and shame that usually comes with the binge eating that a person's experiencing. So those are probably the more common ones that I would say.
Yeah, Alyssa, you did a really good job of explaining those. Um, I'm wondering if you could talk a little bit more too about like body dysmorphic disorder. I feel like sometimes that kind of gets looped in there and is something that other therapists maybe don't know as much about. Like I know that I didn't know as much about that until we started at like the anxiety and OCD treatment center. So do you want to talk a little bit more about that as well?
Yeah, I think a lot of people, they come into treatment saying they have body dysmorphic disorder, just because there is this like, I don't like my stomach, or I don't like my thighs, or I don't like this certain part about my body. And again, the functionality of the two are a lot different. This person is trying to lose weight; they're trying to maintain a certain body fat percentage or whatever that looks like. Whereas someone with body dysmorphia, one, it's not just exclusive to maybe some of these more common areas like thigh, stomach. There's usually not like a weight loss component. It's usually this perceived flaw, whether it's real or imagined, like my nose looks too big and no
Mhm.
one really notices that, or, my shoulders are too broad. And I'm thinking about, when we're thinking about body dysmorphia, there's a little bit of a functionality component that's a lot different than, eating disorders. If we boil these down, it comes down to weight loss and trying to manage weight in this over controlled like weight and shape. Whereas body dysmorphia is a little bit more global. It can really be anything that a person perceives to be flawed.
So it sounds like it's super specific of a body part versus like overall, I'm unhappy with how I look and I need to lose weight, whether that's exercising like crazy, cutting calories, throwing up, right? That's kind of things versus kind of, it sounds like obsessing over a particular body part.
Yes, correct.
Right, which is like the perfect segue into in some of the other episodes I've done with the podcast, I talk a lot about OCD.
Yeah.
I was wondering if we could get your definition of OCD and then kind of after explaining a little bit of the overlap between eating disorders and OCD. And I feel like that body dysmorphic disorder is kind of like that in the middle type
Mm.
of things. So that's why I wanted you to kind of talk about that a little bit more.
Yeah. Well, since you've gone over it a lot, I'll try not to be overly redundant about these things. But, OCD, the two defining characteristics are those obsessions and compulsions. So, obsessions are just the stressing, unwanted thoughts, images, impulses, urges that a person is experiencing. And the major difference, when we're thinking about, we all have disturbing thoughts. I'm sure anyone can think of a time they had a really weird thought and they're like, oh God. So, if I'm having a thought of, I'm going to drive my car off the bridge, I'm like, that was weird. Like, I'm going to continue driving to work or wherever it is I'm going. Where, that obsessionality for someone with OCD is their brain is kind of, I describe it as like tagging that as that's dangerous, that's threatening. What does that say about me? Why did I have that thought? Does it mean that I want to hurt myself in some capacity? And it kind of just gets stuck on a loop there. Um, the compulsive side, then, right, is a person's attempts to neutralize or alleviate a lot of that distress and anxiety. So that could be behavioral. So in that example, I'm not going over bridges anymore. I'm going to take the long routes. I'm going to have someone else drive. Maybe it could be saying a prayer over a bridge, and where it becomes cyclical, where it becomes a little bit um, problematic for people is I say the prayer when I go over the bridge, I feel better. So then I learn, oh, all I have to do now is say a prayer in order to manage my anxiety to get over the bridge. And now I need to do it more and more and more and more. And I can't get over the bridge anymore without saying these prayers. So essentially, the problem here is the compulsions negatively reinforce the obsessions, which essentially means that person's getting short term relief. But as soon as they encounter that trigger again, or as soon as that thing pops up into their head again, they're kind of spinning, back into that cycle. And it really boils down to this concept of a person just has trouble dealing with doubt, uncertainty, and we're trying to help them learn that they can handle some of those things. Um, so the overlap, yes. So this is a fun question, and I'm so happy to talk about it. So, um, you know, just to start, 41% of people with eating disorders also have an OCD diagnosis. So it's not kind of just like this small thing. We're almost seeing about like half our people who have eating disorders most likely are having some undiagnosed or diagnosed eating disorder at the time. Um, and I think when we're thinking about it, right, the core features of both of them tend to be these obsessions and compulsions. So I will try to break it down in the best way possible. But in eating disorders, those obsessions are, about food. They're about their weight. They're about their body image. So how am I going to avoid eating too much when I'm at a party with all of my friends? What if I eat this slice of pizza over the weekend and I gain, all of this weight? What happens if I can't look in the mirror before I go out somewhere? So there's a lot of this just distressing, repetitive thoughts that happen um, in someone who is experiencing an eating disorder. The compulsive behaviors depend on the disorder a little bit. Someone who is struggling with anorexia might engage in a lot of like body checking behaviors. They might cut their food into really small pieces, um, things like that. Whereas in bulimia, we're seeing more of that like purging behavior. Same function as OCD compulsions, right? There's distress, there's uncertainty about body image, uncertainty about food and how it correlates to weight. So I need to do something in order to feel better. I need to do something to prevent this catastrophic outcome from happening. And we kind of see that same thing in OCD. So an example to maybe lay it out is, let's give it a person who has OCD. They're leaving for work and they're constantly checking their purse for keys. Like, is it there? Is it there? Is it there? Take a step closer to the door. Let me check one more time. I'm at the car. Let me check one more time. They're trying to alleviate the doubt that there's the potential that they left their keys in the house. They don't want to forget. They need to be certain about that. In OCD, in eating disorders, we're kind of seeing, again, is I don't know if I can be certain that this certain food won't cause me to gain weight. I'm going to avoid this certain food. I need to, only eat a specific diet. And when we're seeing that, we're like, cool, okay, that definitely looks more characteristic of OCD. That definitely looks more characteristic of eating disorder. But it gets really moneyed. So I'll give another example to really help explain how when a person comes in and gives you maybe just like a symptom, where having this kind of expertise in both can help tease apart. So let's just say someone comes in and they're talking about cutting food into small pieces. I think naturally someone's like probably eating disorder. They're cutting their food into small pieces. I've maybe heard that somewhere before. But it could serve a lot. Yes, the cutting of the small pieces of food could be a way of slowing down eating so they get full quicker. It could be to appear like, look, I ate more that's on my plate. However, it also could be, I need to cut my food into 10 pieces to prevent my mom from dying. I need to cut my food into small pieces until it feels just right. So we're seeing this kind of common symptom on the surface level, but we need to understand the functionality of it as well, because part of the importance is the treatment implications for that as well. We can't apply necessarily the same treatment to that symptom. So that's kind of where it can get a little bit muddied and why it can be really helpful to understand, is this kind of veering off into weight control, body image, shape? Is this kind of going into this, preventing this catastrophic outcome, which maybe Katie has talked about this before. It doesn't make sense. I know that cutting my food into 8 pieces isn't actually going to prevent anything, but I feel like I have to do it anyway.
So fascinating. I did not realize that the overlap was so pervasive. And it makes me think about, I mean, I know that in your particular practice, I'm sure there's a lot of therapists or psychologists who have this overlap, but I haven't heard really it be that common for a therapist to have both specialties, which is a little concerning, but also, right? Because if it's so pervasive and they're coming in for one or the other, how does that work? How do you commonly see, whether it's with other therapists or when clients are coming in saying, I went in for initially an eating disorder and realized I have OCD, but my therapist can't help me, or vice versa?
Yeah, I think it's tricky. I think a lot of people get misdiagnosed. Either way, misdiagnosed with eating disorder, misdiagnosed with OCD. If a person tends to think it's an eating disorder, or let's just say it actually is a eating disorder, they're getting referred out. Like 9 times out of 10, people just don't like touching eating disorders. But I think it's either way. I think a provider either has to know a lot about eating disorders to be able to rule out the possibility that this is OCD. Like, I understand, again, the functionality. I understand the conceptualization of eating disorders to say, this definitely is hitting on something here. And someone with an OCD diagnosis, right, needs a provider to be able to help them really distinguish between the two. And I think about that example I gave with the food cutting. If you don't know to look for underlying differences, well, we might get into a little bit of a mess there. Um, and not saying someone can't help them and work with maybe whatever it is they're presenting, but you're missing a whole other piece of the disorder possibly, or exacerbating. Eating disorder behavior can exacerbate OCD and vice versa. So it's not that people can't get help. I just think when you have such a overlapping commonality between, again, surface level symptoms, it's a big opportunity for something to get missed.
Yeah, I think that, Kira, back to what you were saying with that, I feel like a big part of it that is worth noting is that, I mean, you could make that argument for a lot of
Hmm.
disorders because OCD
Sure.
has its own like comorbidities. I always kind of explain, I'm like, that's kind of in that camp, right? Because there's eating disorders, there's autism spectrum
Mhm.
disorders, there's tics, Tourette's, body focus, repetitive behaviors, ADHD,
Mhm.
trauma. So those are all kind of lumped in with like really common comorbidities. So I think that if you are going to somebody who specializes in OCD, they should at least, at the very least, be able to get to that functionality, like Alyssa's saying, and be able to at least tease it apart and give you a solid diagnosis. Um, and then since it's so common, I think, like, for example, like, obviously, Alyssa specializes in eating disorders and OCD. I focus more so on OCD and trauma related disorders. But I would say that both of us also work a lot with ADHD, right? Like there's an and we also like I could work with a level of eating disorder as well, but if it's something that's more pervasive or intense, like then it's maybe something that I would say, Alyssa, maybe this would be a better kind of client for you. So I think that if you have a psychologist or somebody who at least knows their diagnostics well enough, that at least they'll be able to get a good diagnosis that can kind of help move them forward.
I'm glad you clarified that because I do think it's important. There are so many comorbid comorbidities with a lot of disorders. And it sounds like OCD it overlaps with so many. It's just kind of like the topic or the theme or what else is
That's
kind
right.
of stuck on it that they're obsessing over and having these compulsions over. So, I mean, it sounds like your clients have the best of both worlds with you, which is really great and that you're able to do both so well.
Yeah, I mean, again, I think about it like a one-stop shop, but essentially is, you know, it's frustrating having to go to multiple providers. I mean, I think we can all think about when we've got to like our primary for something and they're like, you need to follow up with this person, this person, this person. And you're like, I don't want to schedule all this appointment. That's really annoying. So it's nice to be able to kind of go to one spot and be able to know that you're getting a really good care for both of those things. But I also think just from like motivation, financial, finding someone who specializes in things is pretty expensive. And, if you're trying to say, go see this person first, then go see this person or see two providers at the same time, that's a lot of financial commitment. That's a lot of motivational commitment. It's doable, of course. I don't want to give that impression that it's not doable, but I think with anything, I think we all like if I can have just a person that does it all, like that would be great.
Yeah, Alyssa, like when I mean, it's not even a, it's definitely more of a burden on the individual experiencing OCD or an eating disorder or both. But I think it's also it's a lot of extra legwork for the
Yeah.
therapist
Mhm.
too, because like Alyssa and I both like, I mean, we collaborate care with other providers, and a lot of times they do like somebody does come in with somebody that they've seen for a long time for therapy, and they want to keep that relationship for other things, but like they're here to just see us for just OCD. And like we take time outside of notes and everything to touch base with the other providers and make sure that that's consistent and that it's on the same track. So yeah. And I think that that's another reason why I love doing the podcast and getting this information out there, is so that it can kind of, it's my little contribution to getting more people hopefully in the know about this kind of stuff, so
Yeah.
that there's less of all of that in the long run.
And so, since you treat both, what are some common therapies and techniques and modalities that you use for treating an overlap of the two? Like, do you separate? Do you do it all encompassing? Like, what is your kind of approach and style?
Yeah. So I think the first thing is the two treatments have similar interventions, but are fundamentally different. So I think it'll be helpful to me explain how they're different and then also how they're similar. So for eating disorder treatment is an example could be is I'm asking someone, okay, we're going to go to a restaurant and you're going to pick out a food that you're scared of, something that you feel like is going to cause you weight, but then afterwards it might be go distract yourself in some way, go call a friend, go watch your favorite TV show, listen to your favorite music, don't sit in this forever. You don't have to. We're just kind of asking you to get over that hump of anxiety. Whereas OCD, right? We're not asking for distraction. We're saying, you know what? You're going to sit with this distress. You're going to sit with this uncomfortability to learn that you can manage it. And we're really asking someone to lean into their fear a bit more. So, like, yeah, I might have, not blown out the candle and my house is going to burn down, but I'm going to stay out with my friends anyway. So, why it's important to know again, I think the treatments is you could accidentally harm or exacerbate symptoms on the other end. And this is where it kind of is helpful and also gets tricky. I think when you're working with someone with both is the interventions can be similar at the same time as well. So family involvement is huge on both ends. We always love when family members or caregiver providers are present with OCD. Family-based therapy, again, it's treatment for adolescents with anorexia. Parents are pretty much involved the whole way through. And I think why caregiver involvement in general is so important is because a lot of accommodations are going on. No one ever likes to see their loved one, their child, whoever it is in distress. So we're just trying to take that load off of them. We're trying to take that burden off of them, not realizing we're making things a little bit more difficult for them. So eating disorder accommodations might be getting special groceries for them, not cooking with butters or things that have fat, but it could be cooking with other things. And unintentionally, we're kind of increasing that power an eating disorder has over a person. OCD might be I'm going to hold the door for you so you don't have to. I'll wash all your fruits so you don't have to touch them. So helping to reduce a lot of that family accommodation is really helping a person indirectly learn that they can handle some of these anxieties and challenges that they're experiencing. So, I think that's a kind of intervention that's seen across the board. Exposure is a big one. Primary strategy for OCD work is doing exposure work. We're saying, again, do the thing that scares you the most. We're going to help you get there, but that is the best way to face your fears is to do this. And we're in some respects doing that in eating disorder work too. We're asking people to see their weight. Sometimes it's the first time they've ever seen their weight. Sometimes it's the first time in a long time. We're asking them to not weigh themselves so much. And in and of itself, that's an exposure. We're asking them to eat foods that they've cut out of their diet or they're really scared of because they think it's going to gain weight. So the exposure piece is really, really helpful across, of course, in OCD, because that pretty much is the treatment. But applying that intervention over into the eating disorder work actually has been really, really beneficial for a lot of people. And then I also think just like the hierarchy piece too is you're gradually having these people confront those things and reduce certain behaviors that are problematic in a way that, in my opinion, fosters a lot of self-confidence. You're tackling these things at a minimal anxiety rate and you're feeling good about it when you overcome it. You feel like you could tackle that next one. Um, Definitely think it helps with the motivational piece. And by the time they get to that top scary thing, which could be petting a dog or gaining 30 pounds, is it just doesn't feel so harmful or scary anymore. So I definitely think having a lot of common interventions is helpful, but also can make it tricky at the same time as when to apply it versus when not
Mhm.
to apply it as well.
Yeah.
Yeah, that kind of segues into another question that I was thinking about in terms of like what do you think are some of the most challenging aspects of treating clients that have both?
Yeah, that's a really good question. I think one of the more challenging aspects is actually helping the person to understand their symptoms, really understanding. And I personally believe spending a lot of time on psychoeducation up front. I don't think there's any benefit in here's what OCD is, here's what an eating disorder is. Like, all right, let's jump into treatment. Like, I want people to feel like I know exactly how this works. I know exactly what this like cycle looks like or what's happening on this end. And I think one of the challenges is really helping a person start to tease it apart on their own, really understanding, okay, this is definitely coming from eating disorder mindset over here. This is coming from an OCD mindset over here. I think the other piece is kind of what I just said is when to apply these strategies. You know, we might say again, practice deep breathing or practice relaxation strategies, eating disorder. But if it's OCD, we don't practice it. I think for kind of a safer route, I'm if a person's not sure, I'm just like, pretend it's OCD then. The worst case happens is you sit with the stress, you sit with anxiety, it goes down anyway. The outcome will pretty much be the same if you're not sure. But I think that's pretty much the hardest part is I think there's just a lot of we need to understand your symptoms. We need to know how they play out and like potentially where they're coming from in order for us to effectively treat them along the way.
So it sounds like a very thorough beginning, right? Like intake process, understanding what's going on for them, what their life looks like, their family. And that made me think about an episode with Katie of how their family can be involved. And it
Yeah.
almost feels like, counterintuitive of like not enabling them, like doing things outside of what would relieve that stress and anxiety so that they can actually do it on their own. So it sounds like a lot of these things are difficult, contradictory, but then also kind of mesh well together as well.
Yes. Yes. And that's hard to explain to people is this contradicts itself and at the same time it works for both. And they're kind of just like, what? But I think once people really get the hang of it and start to again learn more about themselves and their symptoms and how they manifest it, it becomes a little bit easier along the way.
Do you have any success stories or kind of being able to walk somebody who has an overlap and like what progress would look like or what healing would look like for them if it's not someone in specific?
Yeah. So a while ago, I worked with someone who came in for anorexia. And, I think one thing I should have mentioned is regardless of what the person is going through, if they are underweight or malnourished, that is the top priority. You just can't do treatment if someone from a medical standpoint is not healthy, but also thinking about if you've ever tried to do something when you're starving, it's not easy to concentrate. It's not easy to take in information. So her and I really worked on like that weight restoration piece first, getting her to a healthier weight so we could engage in treatment. And a lot of her, you know, symptoms from an OCD perspective were around fear that she could like ingest something that would like change her body composition and lead to all of these like weight related changes. She was kind of the example I was alluding into with like the cutting. There was also like a piece of like I need to cut certain foods in order to prevent like choking or like accidentally throwing up because she was averse to throwing up. Um, we did a lot of exposure work to like feared foods and stepping on the scale and things like that. And I mean, I would say from start to finish, it was definitely a bumpy ride. This person had not previously known that they had an OCD diagnosis, and having to really go through a lot of that, not back work, but hey, there's this other thing here that I think is actually making the eating disorder a little bit worse, and potentially exacerbating a lot of these symptoms. We really need to tease this apart a little bit and treat the two more simultaneously together. And I think that ended up opening up like a whole different door for us. Like treatment went so much more smoothly. I'm talking about probably for like 3 to 4 sessions. We were like, should we be doing this anymore? Like, I think we're at a standstill. Like, what do we do here? And I think for this person in particular is we were totally minimizing something else. We didn't realize this other thing was going on, and just kind of having that extra knowledge and being able to treat some of those OCD symptoms allowed some of the eating disorder behavior to come down to some degree as well. But we were alleviating a lot of stress and anxiety on some other end. Um, but yeah, I mean, well, I don't see her anymore. I haven't heard from her. So I'm assuming that she's doing really well and has moved on with things. But it was a really cool example. And I bring her up because she was the first person I saw with OCD and
Mm,
um, eating disorders. And that's where I was like, oh, okay, these two really do coexist. And there's such a symptom overlap here. And not in the way, again, we're thinking about like OCD behavior is over here and eating disorders here, but like a lot of food related OCD obsessions and compulsions that made it tricky.
mhm. Yeah, I bet. That sounds well, I'm glad you were able to help her and that kind of sparked your interest and inspiration into wanting to delve deeper into it.
Yeah, it was a very interesting and fascinating case.
Listen, do you feel like there's any common misconceptions about OCD or eating disorders that you think need to be addressed in the therapy community?
I think there's a lot. Yeah, I think
I mean, for sure with OCD, yeah.
we could probably do a whole another
I know, that's
podcast
what I always say
on
to
just
Kira. I'm
this.
always like, "Well, this question could be a whole episode."
This could be a big one. Yeah, I mean, these probably are repeated, and these are probably things that are very much out there. But just the idea that like OCD is being characterized as this personality trait or this unique quirk that people have. We hear it all the time. I'm so OCD. I'm so OCD for this, and it kind of minimizes, in my opinion, what someone with OCD is actually going through.
Yeah.
They're struggling. They're suffering. Some people are homebound. They can't leave their houses or function on their own anymore. That's not pleasant. When someone's describing, I'm so OCD, it's usually, I like cleaning until it's spick and span, or I like organizing until it looks
Mm,
a certain way. And that's different. You know, if you like it, it's not a disorder. You're
mm,
enjoying engaging in this. And I think more than anything, it's just, I can't imagine as a person if I was struggling with OCD to hear people throw around that term so loosely and knowing what the struggle actually looks like. I think the other big one that comes up for me is what OCD is. And I think this goes into why it can be so missed. Like most people aren't actually getting treatment for like 10 years when they have OCD. Like there's a huge gap in there. And there's probably other reasons in there as well, but you have the people come in and they're like, well, I don't wash my hands, or I don't clean stuff, or I don't organize stuff. And really helping people to understand that OCD is so much more than just hand washing or taking long showers or being overly clean. But we have harm OCD where people are afraid of hurting themselves or other people. Or we have scrupulosity and religious. And I know Katie did a whole wonderful podcast on that. And, um, you know, OCD is really anything that you care about. If you care about it, it's going to go after it. And in really helping people to see like it's pretty broad. And that's why people's symptoms can be so all over the place when you're working with them. But I think those are probably two of my biggest one. And then I think in more of the eating disorder context, I think one of the bigger misconception is people think that there's like a choice in having an eating disorder where really it's not a choice. It's there's a lot of brain abnormalities that are happening. People are kind of born with these abnormalities that predispose them to eating disorders. And I have a great example is I had a patient who was just sick, like flu or something like that. And she just lost a bunch of weight because she was sick and couldn't eat. And when she recovered, she was anorexic. All it took is her to lose too much weight and then a flip switched on in the brain and she was in treatment for anorexia. So, I highlight that as she didn't choose to get sick and she certainly didn't choose to recover with now a whole another problem on top of her. But they're really, you know, difficult disorders. And I always kind of lightly say with my patients, I'm like, there's a good chance that you didn't wake up one day and just say, I want an eating disorder. I want to, really struggle with all of this. It's just not something that you ever hear. Um, the other one I think that could be a little disheartening too is parents think it's their fault. I work with parents all the time. And they're like, I did something. I caused this to some capacity. I made a comment, back 10 years ago about something. And it's really difficult to help parents really externalize that eating disorder from their child and say, you didn't actually do anything. You didn't cause this eating disorder to happen. You didn't do anything that made this happen. It just biologically predisposed. We have environmental factors, society. That could also be a whole other podcast on society and how it plays into eating disorders. And I think really helping people understand that there's nothing you did or said that caused someone to have an eating disorder. It's just kind of a perfect culmination, a perfect storm of all of these factors that had come together to get your child sick. And you're part of that like medicine, if you will, to helping them get better rather than the problem.
I like that reframe. That's really good.
Yeah.
Yeah, part of that medicine. Another one that I like was just thinking about as you were talking too that really bothers me is that I think a lot of people think that like you don't have an eating disorder unless you're like stick thin, right? Like people in larger
Yes.
bodies can also have eating disorders as well, and like that can be really harmful to people.
Absolutely. Again, when we probably close our eyes and think about eating disorders, I think everyone, I shouldn't say everyone, a majority of people would probably pick the anorexic person. And treatment gap here, right, is this is why people don't often get treatment for eating disorders right away is people with binge eating disorder could be normal or overweight. People with bulimia could be average weight, a little bit underweight. They could be overweight. But because we don't meet that stereotypical idea of what an eating disorder looks like, people are like, I'm fine. I'm not actually sick. Or no one's noticing. I can still fit in all my clothes. I can still do all the things that I'm doing. It can mask itself. You're still functioning. You're still looking outwardly healthy, but internally, mentally, you're struggling. I think that's a really good one. Is it's still really hard to break people away from that misconception of outwardly what it looks like. It's a little bit silly it is to just diagnose someone straight outwardly too of, you do or don't just because of your body composition.
That's such a great point. And it sounds like I'm just thinking about all these different practitioners, right? Like not knowing some of this or, like quick snap judgments. Is there any piece of advice that you could give clinicians who may not specialize in one or either that can give them something to kind of look for, differentiate, just to kind of stand out in that way?
Yeah. I mean, definitely like ask all the questions. Katie and I, she mentioned collaborating with other providers. And I think there's more people out there that are willing to help and help you understand because after all, we all got into this field to like help people. We're trying to get them through to the end of that treatment recovery road. And we want to be able to provide any insights or resources or helpful stuff. So I think, connect with people in either community, whether you are unsure if you're going to go into that route or you might end up working with people this way. It's just immerse yourself into OCD, eating disorder community, reach out to people. I get emails from people at like undergrad schools or like training master levels, and they're like, hey, I'm really interested in this. Like, can you talk? And I'm like, absolutely, I would love to help. And there's so many free webinars, talks, resources. If you have the money, conferences, just even just attending as a person to walk through and learn about all of these things, there's so many opportunities out there that are accessible, easy, affordable, for you to be able to learn a little bit more about eating disorders or OCD. And even, I'm attending a free hour talk on the comorbidities between the two. It's just kind of looking around and finding those opportunities and jumping on them.
What a wealth of knowledge. Thank you so much. This has been super informative. Before we hop off, can you share if there's any resources for individuals struggling with these things or any kind of tidbits or advice for someone who might be struggling with both of this?
Yeah, I mean, I have definitely a bunch of resources, and I'm going to selfishly plug the book that my owners of the practice did. It is on how to treat comorbid eating disorders and OCD. Um, it's actually really, really helpful. It goes through everything we talked about what eating disorders are, what OCD is, what the treatment similarities, differences are, how to treat people, case examples. It's a really, really helpful book. Um, in terms of resources for eating disorder community, there's the Academy for Eating Disorders, which is great. That's where a lot of the conferences come from. There's huge networking events that you could attend from there. There's National Eating Disorder Association, NEDA. They are constantly doing events like walks. Like I think they do a eating disorder recovery walk in every major city, throughout the year, and they're constantly doing advocacy or volunteer opportunities to get involved. So those are Feast is another eating disorder website for individuals who are suffering with anorexia, and more of like a parent resource, I think, to help them figure out how to manage a child with an eating disorder, and just some helpful resources there. And then, of course, there's some really good books. There's the treatment manual for anorexia. There's Chris Fairburn's CBT manual for eating disorders. So there's a lot out there. Um, on the OCD front, I think the IOCDF, which is their big international webpage for everything and anything. I pretty much always refer people there when they're looking for resources or books or anything. I'm like, here, here, here. I think there's a lot of good researchers and people who have a lot of published books. There's John Grayson, who has like one of my favorite books, Freedom from OCD. That was kind of like my training book, if you will, to get into OCD. There's Eric Storch, who does a lot of research and constantly doing studies for people. Uh, Eli Leibowitz, John Abramowitz, John Hirschfield. There's so many good people that just keep pumping out a lot of helpful books and resources. So pretty easy to find them, which is actually really nice.
We will definitely list all of these in the show notes. That was
Yeah,
fantastic. Thank you. You have so much knowledge and expertise on this. I'm so happy you were able to join us today. This was incredible.
I'm so happy you guys asked me to come. This was a lot of fun.
So if anybody wants to work with you, find you, can you share where they can get in touch with you?
Yes, so I work for the Center for Hope and Health. So easy enough to just kind of plug onto into Google. There is phone number, there's an email. I specifically work out of in Texas for people who might be interested in more that area, but I also have a license that allows me to practice across state borders as well. So whether you're in New Jersey, PA, Oklahoma, whatever it might be, is they can still reach out to that number. And if they're looking for resources or treatment, that's how they can reach me.
If you've enjoyed this episode, please like, share, and subscribe. Alyssa, thank you so much for being on. Katie, thanks for being our co-host. This was a phenomenal episode. It's a wrap.
So this is my first time co-hosting. I'm really excited. Please share your thoughts and feelings in the comments section, and we'll check it out later.